Hi, my name is Yao Biafe. This presentation is a flip classroom lecture on ultrasound of the gallbladder. The objective of this class is to briefly talk about the anatomy of the gallbladder, the sonographic technique for assessing the gallbladder, and the ultrasound assessment of gallstones disease as well as changes in the gallbladder wall. The gallbladder is a pear-shaped organ you would find in the right upper quadrant, just at the inferior margin of the liver. By its location, it divides the liver into two halves. The major landmarks we can use in determining the gallbladder is the portal vein, interlobar fissure, and middle hepatic vein. The gallbladder consists of three main portions. There is a blind end portion of the gallbladder which is called the fundus, and then the middle part of the gallbladder called the body, and the most inferior part that connects to the cystic duct is called the neck. In terms of size, the gallbladder measures up to 4 cm in short axis and up to 10 cm in long axis. Here is an image of the gallbladder, and you can see landmarks including the portal vein over here and the middle hepatic vein also showing here. This echogenic line is representing the interlobar fissure, which is found in about 70% of the population. Over here too, you find an image of the gallbladder with this representing the fundus, this mid portion representing the body, and then the neck that connects to the cystic duct. However, the appearance of the gallbladder varies with physiologic changes, depending on whether or not you have eaten. During fasting, the gallbladder distends with bile, and the gallbladder wall appears thin. But after taking a fatty food, the gallbladder contracts, and the gallbladder wall appears thickened. You may also find congenital anatomy variations in the appearance of the gallbladder of some individuals. The Phrygian cup and the junctional fold are the two most common anatomy variations you may find. The Phrygian cup is a fold at the close to the fundus of the gallbladder, and the junctional fold is also another fold you may find closer to the neck of the gallbladder. Other uncommon congenital variations you may find include septation, bilobed gallbladder, hyperplasia or hypoplasia of the gallbladder, duplication, as well as agenesis of the gallbladder. Here is an image of a Phrygian cup. You can see the fold within here, and on the sonogram, this fold will appear as an echogenic line within the lumen of the gallbladder closer to the fundus. Here is an image of a junctional fold, as you can see closer to the neck of the gallbladder. It shows on this sonogram as an echogenic line within the lumen of the gallbladder closer to the neck. In terms of patient preparation, a minimum of 4 hours of fasting is recommended. Early morning appointments are ideal as it allows for a longer fasting period of 8 to 12 hours. As your first activity in this class, I would like you to arrange an ultrasound of the gallbladder for a volunteer in the morning before they take their breakfast. Measure the size of the gallbladder in long and short axis. Measure the thickness of the gallbladder wall, and also find out whether there is a congenital variation with the gallbladder. Again, check whether there is any echogenic structure or collection within the gallbladder lumen, and find out whether there is any posterior acoustic shadowing accompanying the echogenic content. Afterwards, find a way of getting your volunteer to take in a fatty meal, and then assess the gallbladder as you did earlier on. Present a long and short axis images of the two images you've acquired for the preprandial and the postprandial scans. In terms of sonography technique, a 3 to 5 MHz sector probe or curvilinear probe is recommended for deeper penetration. You can place the probe midway along the costal margin of the right upper quadrant with a notch pointing towards the shoulder in long axis, and then with a notch pointing towards 9 o'clock in short axis. You may also ask the patient to take in a deep breath if you are trying an intercostal approach for better visualization. Multiple scanning positions may be necessary, particularly when there is a pathology showing. You could scan in the supine, left posterior oblique, left or right decubitus, prone or upright positions. Scans must be obtained from both sagittal and transverse planes. Here is an image demonstrating how you must be holding the probe midway along the costal margin with a notch pointing towards the shoulder in long axis. And here is an image showing how you must hold the probe with a notch pointing towards the right side of the shoulder in short axis. As your second activity for this class, I would like you to discuss a recent ultrasound that was performed at your clinical site with your supervisor. What were the clinical indications for the ultrasound? Did the patient have to fast for the procedure? Were there any abnormal findings you would like to talk about? Did the patient have to change position because of an abnormal finding, and why? What were the differential diagnoses for the of the ultrasound? Assessing gallstones disease is considered an important part of the examination, as gallstones disease are associated with cholelithiasis, cholecystitis, porcelain gallbladder, and gallbladder cancer. The sonographic diagnosis of gallstones disease is determined by the detection of intraluminal echoes with posterior acoustic shadowing. It is important that you find out whether the gallstones are mobile or impacted by scanning from different positions. You also need to differentiate gallstones from gallbladder sludge. Here is an image of the gallbladder with gallstones showing within the lumen. You can see that there are achogenic foci within the gallbladder with posterior acoustic shadowing. In this particular stone, you can see that it is located at the region of the neck and appears to be impacted. So you need to scan the patient in different positions to make sure that it is not moving. Over here is also another image of what was found out to be a polyp. You can see that it is not showing any acoustic shadow, and again you have to scan this patient in different positions. Assessing changes in the gallbladder wall is considered an important part of the examination. The determination of a gallbladder wall thickness of more than 3 mm is considered abnormal. You also need to rule out calcifications and whether or not they are diffuse or focal. Polyps, as I indicated above, should be scanned in different positions to confirm that they are attached to the wall. Again, in case you come across any echogenic focus within the wall, find out whether there is a comictal artifact associated with it. Here is an image of the gallbladder. Again, you can see that the walls are thickened. There is even pericholecystic fluid around it. You can place the probe over the region of the gallbladder and compress it to see whether there is any sign of pain. It is called the sonographic Murphy sign. As your third activity for this class, I'd like you to read chapter 6 of Diagnostic Ultrasound by Romack and Co. and answer the following questions. What is the difference between cholelithiasis and cholecystitis in connection with gallstones disease? How would you differentiate wall echo shadow complex from porcelain gallbladder? And present a list of gallbladder diseases you found in the textbook and the wall changes associated with them. Hope you had a great time. Thank you.